Hi, my name is Jincheng. I'm a second-year pediatric clinical pharmacology fellow at University of California, San Diego. Over the last year, I have been working with our mentor, Dr. Caprelli, on various pharmacometric projects. One of the projects we examined was a population pharmacokinetics analysis on VRCO1LS, a broadly monoclonal neutralizing antibody. We assessed drug exposure in term infants following subcutaneous administration. The title of the presentation is Population Pharmacokinetics of HIV-Specific Broadly Monoclonal Neutralizing Long-Acting Antibody VRCO1LS in Term Infants. I have nothing to disclose. Despite advancements in antiretroviral therapy, there remains a need for innovative pediatric formulations to ensure compliance. Broadly neutralizing antibody, or BNAbs for short, are currently under development as prophylactic use and for the treatment of HIV infections. HIV prevention in breastfed infants especially remains challenging and requires more therapeutic options. As such, BNAbs can serve as a therapeutic option for these patients. Amino acid modification of Fc region of BNAbs can reduce clearance and extend duration of serum half-life to allow less frequent dosing. VRCO1LS is the first long-acting BNAb that incorporates this Fc region modification for extended half-life. More specifically, it has 2 amino acid modifications in the Fc region and can extend the duration of its serum half-life up to 5-fold compared to VRCO1. Mechanistically, this antibody blocks CD4-GP120 interaction to prevent viral entry. And this LS formulation is administered subcutaneously every 12 weeks or 84 days, whereas VRCO1 is every 4 to 8 weeks, depending on the formulation. Here, I have listed the pharmacokinetic differences between VRCO1 and VRCO1LS in adults. These 2 amino acid changes provide 10-fold decrease in clearance and 4-fold increase in half-life compared to VRCO1. To better characterize the pharmacokinetic differences between VRCO1 and VRCO1LS in infants, we conducted the VRCO1LS population pharmacokinetic analysis from a phase 1 study, IMPACT P1112, following subcutaneous administration in early infancy. Here are the population included in our PK analysis, which included a total of 21 infants and 157 samples. The cohort was split into Arms A for non-breastfeeding infants and Arm B for breastfeeding infants. The infants were dosed based on body weight, as depicted here. So patients less than 4.5 kilograms received the 80 milligram dose, and those greater than 4.5 kilograms received the 100 milligram dose. The demographics between the 2 arms were similar. Please note that patients in Arm B, or the breastfeeding group, were provided with a second dose at week 12 for additional protection. For the model, the 2 arms were pulled together into a combined data set and was modeled using a 1-compartment model. Clearance was scaled to 0.85, while VD was scaled to 1. Age, captured as time greater than 12 weeks, was assessed as a covariate. Breastfeeding, sex, as well as location were also assessed. Next, a bootstrap with 1,000 iterations and a virtual predictive check were assessed for model validation. Lastly, we performed a Monte Carlo simulation to capture VRCO1LS exposure and later on predict possible fallen concentration due to growth. The graph here depicts the overall plasma concentration profile for VRCO1LS for each arm in log scale. On the y-axis, we have time after dose in weeks, and on the y-axis, we have VRCO1LS concentration in micrograms per milliliter. The concentrations are stratified by study. Arm A is depicted here in black, while Arm B is depicted here in red. Please note that the Arm B received the second dose at week 12. During our pre-modeling analysis, VRCO1LS concentration of infants follows the trend of a normal concentration profile for both arms. Since the plasma concentration falls mono-exponentially with time following subcutaneous administration and is log linear, we decided to go with a 1-compartment model. To validate the model, both observed versus predicted VRCO1 concentration and CW-RES were assessed. The observed versus predicted VRCO1 concentration is centered around the line unity. In addition, CW res versus time after dose is evenly distributed above and below zero, indicating no major bias in the model and no time-dependent kinetics nor dose accumulation. Here we have a virtual predicted check where we simulated a single 80 mg dose in infants. The dashed line here represents a 95% confidence interval of the simulation. The red line here is the PD target of 50 micrograms per ml, and the blue is 20 micrograms per ml. The blue dots here are the raw concentration, and they fall reasonably within the confidence interval, indicating that the model is adequate. The final model parameter values are displayed in the table shown on the left. Following model building and for validation, we conducted bootstrap with 1,000 alliteration, and its median value matches the final parameter values. Out of the 12 covariates screened, 1 covariate was kept in the final model. Age captured categorically as greater than 12 weeks or 84 days, the time when second dose is given, was best captured on VD. I want to bring attention to the equations on the right. Looking at the equation, our final model for parent clearance included allometry scale weight, which is scaled to 0.85. The equation tells us that heavier infants tend to have higher clearance. Since there is substantial growth during the first 12 weeks of life, from a median weight of 3.3 kilograms at birth to 5.7 kilograms at 12 weeks, there is a 59% increase in parent clearance during the first 12 weeks of life. Volume of distribution was scaled by weight and described by age effect. Using a typical 5.7 kilogram patient, the model predicted values slightly higher than normal infant plasma level, indicating that VRCO1LS have limited ability to distribute into peripheral tissues. In addition, by factoring both growth as weight and categorical age, patients have substantial 37% increase in parent VD during the first 12 weeks of life. As the monoclonal antibody remains mainly in the plasma, there is a hemodilutional effect that contributes to the fall of VRCO1LS concentration during growth. For the Monte Carlo simulation, we simulated patients receiving single subcutaneous dose of 80 mg, 100 mg, and sequential 80 mg followed by 100 mg after 12 weeks. For the study, the target VRCO1 serum level is greater than 50 mg per ml for greater than 6 months, which is 10 times higher than the in vitro IC50 concentration of 5 micrograms per ml. This can neutralize the majority of circulating viral strains. In the article by Wu et al., 91% tested isolates have IC50 less than 50 micrograms per ml. This is depicted here in the figure to your right. The blue represents the concentration 1, red as 5, and dark red as 50 micrograms per ml. As you can see, a VRCO1LS concentration of 50 micrograms per ml would cover IC50s for most tested isolates. For all three simulations, as depicted here, greater than 99% of simulated infants have C-trough greater than 20. However, this is substantially less for patients with C-trough greater than 50 micrograms per ml. Only 27% have C-trough greater than 50 micrograms per ml after a single 80 mg dose administration, and only 61% after sequential administration. Thus, a higher dose and more frequent administration will be needed to maintain a targeted serum level of greater than 50 micrograms per ml. In conclusion, the current study represents the first POP-PK evaluation of long-acting BNAbs in early infancy. Simulation of the current dosage studied is projected to maintain concentration greater than 20 micrograms per ml for 6 months in virtually all infants. Higher dose or more frequent administration will be needed to maintain concentration greater than 50 micrograms per ml in most of the infants. Also, we noted that there is a dilution effect from early growth that contributes to the fall in VRCO1LS concentration. Lastly, I'd like to thank my mentors, the Impact Network, and my colleagues at UCSD for their support on this project. Without them, this project would not have been possible. Thank you for listening, and I shall take questions.